Hello everyone, I will be speaking on how to interpret the culture and antibiotic sensitivity reports of microbiology. Microbiology reports are very different from the pathology and the radiology reports. In the way they are multi-part results. Each of the microscopy reports further has sub-parameters like microscopy, culture identification, and culture sensitivity. Let us understand how to interpret these sub-parameters. To begin with, we'll start with microscopy. Before that, let us understand that the question that arises for the clinicians and the lab technicians. The question that arises for the lab technicians and the clinicians are as follows. For the clinicians, how the microbiology laboratory results can influence the antimicrobial prescription or patient management. And for the lab technicians, how a particular sample needs to be processed in a correct way and which samples need to be taken or considered for sample testing. From a clinician point of view, how to interpret the microscopy results. When a microscopy report is released, it often carries the morphology of the organism. The morphology often states about the pattern of the organism, whether it is in chains or pairs, whether it is gram positive or gram negative. How to interpret these results? It needs to be interpreted in correlation with the clinical history. For example, take an example of sputum sample. A patient is presented with symptoms like cough, breathlessness, and fever, and the possible diagnosis is pneumonia. And if the gram test report states that the gram positive cocci is in chains, then it is indicative of infection and is probably by a streptococcus group of organism. This is how microscopy results, the gram stain results of the morphology of the organisms can indicate infection and a probable organism. Similarly, along with the morphology of the organism, the other two factors that are important while interpreting samples is pus cells and epithelial cells. For example, in sputum sample, there is a criteria called as Bartlett's criteria or Q score. The criteria mentions about scoring, say +2 if the WBCs are more than 25 per field, +1 if the WBCs are in the range of 10 to 25 per field. It is -2 if the epithelial cells are more than 25 per field, or -1 if it is between 10 to 25 per field. So, to simplify, a sputum sample is significant only if the WBCs are more than 25 per field, or if the epithelial cells are less than 10 per field. So that's how pus cells and epithelial cells can help us guide whether it is indicative of infection or contamination or colonization. If there are no pus cells, then it rules out infection. For example, in sputum sample, it rules out pneumonia if there are no pus cells. And the sample is significant if the gram stain mentions about more than 25 WBCs per field or less than 10 epithelial cells per field. And the gram stain mentions about a presence of a single dominant bacterial morphology. Then it is indicative of infection, and then this report can be used to adjust antibiotic selection. If the epithelial cells are more than 25 or WBCs are less than 25, then it is not an infection, it indicates contamination or colonization. In such cases, avoid unnecessary cultures. Help us to see whether the particular sample is contaminant or infection. The other thing is that if the gram stain shows multiple organisms, we say it's a root of 3. If there are more than 2 types of organisms, then it is non-specific and cannot be relied upon to modify the therapy. In such cases, also avoid unnecessary cultures. Again, take an example of urine sample. In urine sample, absence or presence of pyruria is very important. Absence of pyruria largely excludes UTI. It's a good tool to reduce unnecessary cultures and antibiotics. Presence of pus cells, that is more than 10 WBCs per microliter, is also indicative of infection. Bacteriuria, it indicates bacteria and warrants antibiotic administration, but only in symptomatic patients. In asymptomatic patients, presence of pus cells needs to be correlated carefully. Pyruria can also occur in absence of infection. In cases such as patient with antibiotic therapy or contamination from vaginal secretions or colonization or patient on catheters or asymptomatic bacteriuria. So presence of pus cells or absence doesn't mean it is UTI. It needs to be interpreted cautiously in accordance with the clinical conditions. Let us understand the key phrases that is used in microscopy results to understand the interpretation. In microscopy, often there is a mention of the gram positive or gram negative and its pattern, whether it is in clusters or pairs. When it is a gram positive cocci in clusters, it indicates Staphylococcus species. When it is a gram positive cocci in pairs and chains, it indicates Streptococcus species or Enterococcus species. If it the microscopy mentions gram negative Coccobacilli, then it indicates Haemophilus species. If it indicates, if it mentions lactose positive gram negative rods, lactose positive means pinkish colonies gram negative rods, then it indicates Enterobacteriaceae, such as E. coli, Klebsiella, or Enterobacter species. If it is mentions lactose negative gram negative rods, then it is non-fermenting bacilli such as Pseudomonas, Acinetobacter, Burkholderia, Pseudomonas, and others. So this is how microscopy results can help us indicate a particular organism, which gets confirmed only on its culture growth and identification and sensitivity. And a few other examples such as are as follows: branching gram-positive rods, and which is acid fast positive, it indicates Nocardia of Streptomyces species. If it is acid fast bacilli, it indicates Mycobacterium species. If it is yeast, which is budding yeast cells specific, then it indicates Candida species. And further to see whether this Candida species is pathogenic or not, we do, or in other words, it is Candida albicans or not, we do a germ tube test. And if the germ tube is negative, it is non-albicans. If it is positive, it indicates Candida albicans. So this is how germ tube is a quick test about it. It takes about 2 hours, and it can indicate whether it is albicans or non-albicans, and then this can be used to for interpreting a particular yeast report in a microscope results. The other example is round yeast cells. It indicates Cryptococcus species. Then there are fungal elements or branching filamentous elements on microscopy. It indicates fungal elements or to be specific molds. So this is how microscopic results can help us to interpret the microbiology report to indicate whether it is infection or colonization. However, what is it's an in vivo results, and it identifies bacteria or fungi present, but it doesn't tell us whether it is an infection or colonization or contamination. For that, it needs to be interpreted in correlation with the clinical signs and symptoms. How to differentiate this infection or contamination? For example, let us understand the habitat of the organisms. That's very important. For example, isolation of Enterococcus faecalis from urine is important for a symptomatic patient, but it is not of no value in a sputum sample. Similarly, Candida species, which is often a commensal of the respiratory tract or urinary tract, is rarely pathogenic in these samples. Then group B Streptococcus does not cause UTI. It represents only colonization from a vaginal tract, unless in pregnancy when it needs to be treated. Then Streptococcus pneumonia, it doesn't cause infection of pharynx, but if it is isolated from throat swab, it suggests colonization. E. coli isolated from leg ulcers is again colonization, and it does not have the potential to cause infection at this site. This is how the habitat of the organism can help us to understand whether it is an infection or a colonization. It all the other thing that is important is the colony count or the quantitative value of the culture, which again depends upon the source of the culture, the gram strain results, patient gender, and other such factors. Let us understand the quantitation value. What do you mean by colony count? For example, a single colony count of any organism is very significant in a blood culture sample. Before I move to the details of the colony count, let us understand the blood cultures. Blood cultures, we do the test for diagnosis of sepsis. But for a correct rational way of to do a blood culture, it has to be two sets of blood cultures needs to be collected. One set from the left hand, one set from the right hand, and each set should consist of one aerobic bottle and one anaerobic bottle. Now why so? The more the number of bottles or more the number of blood, the larger the blood sample, there is more yield or sensitivity of isolation of or positive growth from a blood sample. See, understand this thing that not all the organisms are strictly aerobic or strictly anaerobic. Most of the organisms are facultative to anaerobes like Staphylococcus, Streptococcus, E. coli, and Klebsiella. That's why we need to create both aerobic and anaerobic bottle, and that too from both the hands, because blood bacteremia or septicemia is not always continuous. It occurs transient or intermittent. Hence, samples need to be taken an hour apart from both the hands, and it should include both the aerobic and anaerobic bottles. If a particular organism is isolated from a left hand but is not isolated from a right hand, then depending upon whether that sample is a pathogenic or contaminant, the blood cultures needs to be interpreted accordingly in correlation with the clinical signs and symptoms. And let us understand how to interpret or identify or diagnose catheter-associated bloodstream infection. For catheter-associated bloodstream infection, along with the central line, peripheral line needs to be collected. Peripheral line blood culture needs to be collected. And if the catheter cultures turn positive more than 2 hours earlier than the peripheral culture, if there is a gap of less than 2 hours earlier than the peripheral culture as compared to the catheter cultures, then it is central line bloodstream infection. To simplify, if the peripheral cultures and the catheter cultures all turn positive within 2 hours of one another, then it is a bacteremia from another source, or it is a line infection. It is not a catheter-associated bloodstream infection. Catheter culture turns positive, but the peripheral cultures are negative, then it's a contamination or colonization. So this is how these factors need to be considered while interpreting catheter-associated bloodstream infections. For urine culture, for a symptomatic patient, the cutoff colony count is 10⁻³ per ml. However, if there are two types of organisms, then a growth of one organism more than 10⁻³ and another organism less than 3, then it is significant. If there are more than two types of organism growth on a sample, then it is a contamination. This is how the colony count can be used to interpret the urine cultures. Do not treat asymptomatic patients except in case of pregnancy or any procedures. And do not treat contaminants. The colony count of less than 3 in urine culture is also significant in case of catheterized urine specimens, then urethral syndrome, a patient is on antibiotics, or obstruction or pyelonephritis, or there is a specimens collected by suprapubic aspiration. So this is how urine culture needs to be interpreted considering the colony count. Similarly, in respiratory cultures also, colony count is very significant. But no growth of any pathogen roots of pneumonia unless antibiotics were initiated before cultures were obtained. Positive cultures from tracheal spread alone does not prove that the presence of pneumonia. They may result from colonization. Hence, colony count is very important. However, certain species may be more likely to represent colonization than invasive infection. For example, Enterobacter, Proteus, Burkholderia, and Enterococcus. So, colony count cutoff for different samples of the respiratory tract. For ET secretions, it is 10⁻⁶ colony count per ml. For bronchial lavage, it is 10⁻⁴. And for protected specimen brush samples, it is 10⁻³ colony count per ml. When we say colony forming units, it represents 10⁻⁶ organisms. So this colony forming units per ml in a respiratory tract needs to be considered while interpreting any sample as a significant significant or not, whether it is indicative of infection or colonization or contamination. So this quantification needs to be done only of invasive obtained samples such as bowel fluid or protected specimen brush samples. Quantities of bacterial growth above threshold as indicated here are diagnostic of pneumonia, and the quantities below this threshold are more consistent with colonization. So this is how we have to interpret the microscopy results, how to interpret the colony culture results. In my next session, we will see how to interpret the sensitivity results, antibiotic sensitivity results in detail.